Good afternoon, everyone, and welcome to Within's Continuing Education webinar series. My name is Ashley Barkowiak, and I'm the Clinical Operations Coordinator here at Within Health. Today, I have the absolute pleasure of introducing you to our presenter today, Cheryl D'Amato. Cheryl is a senior therapist here at Within Health. She graduated from John Jay College of Criminal Justice with a master's in forensic psychology and forensic mental health counseling. She went on to receive further specialization in substance use disorder treatment and received her certification of alcohol and substance abuse counseling in 2022. I also am lucky to share that Cheryl also just received her CEDS certification this year, so congratulate Cheryl on receiving that recently. Although she has worked in the mental health field, providing treatment to a variety of people with a variety of needs, she has found that the field of eating disorders and substance abuse disorders to be of a particular interest to her. Cheryl is passionate about healing a person in every domain in order to find sustained recovery from both eating disorders and substance abuse disorders. Before we start, we do have some general information to go over today in regards to the CEU and CME credits. I will now pass things over to Jamie Singletary, and she will go over the CME credits.
Thank you, Ashley. Good afternoon, everyone. And again, thank you for taking the time to join us this afternoon. I just want to go over a few housekeeping items in regards to obtaining your CE credit and your CME credit. For those of you in attendance today that are looking to get a CME credit, please email me directly and I will provide those instructions on how you can obtain your certificate. If you are just looking to do the CE credit, all of that information will be in your dashboard. Thank you.
Wonderful. Thank you, Jamie. And as Jamie mentioned, all of that information will be available on your CE Go dashboard. We will not be providing the slides today. However, the video is being recorded and that will also be available on that CE Go dashboard. You will not get credit for watching the video. You do have to attend live today. And again, there will also be that video, and we do have several handout materials available from Cheryl's presentation, and that will also be available on your CE Go dashboard. So make sure you check that out. We have a lot of great resources that'll be coming up on that dashboard. If there's any additional questions, concerns regarding obtaining that credit, or if you have any issues accessing the provided handout or links, please feel free to email myself or Jamie. I will also provide CE Go's contact information in the chat as well to make sure that we have you covered on all angles. I will now pass things over to Cheryl. Also, we will be monitoring the chat and the Q&A. If any questions do arise throughout the presentation, please utilize those features. And again, thank you, Cheryl, for presenting. We are so excited to have you.
Thank you so much, Ashley and Jamie. And thank you all so much for joining me today to discuss how treatment for substance use disorders and eating disorders intersect. We know that treating the whole person provides the best possible outcomes and sustained recovery. I look forward to exploring with you the ways in which we combine treatment for eating disorders and substance use disorders. So statistics demonstrate a high co-occurrence of eating disorder diagnoses and substance use disorder diagnoses. This can create a more complicated diagnostic profile, which requires more considerations for treatment planning. There are similarities and differences in the contributing factors to, assessment of, treatment of, and recovery process from substance use disorders and eating disorders to be aware of. This can feel like a maze if we are not familiar with the ins and outs of treating both eating disorders and substance use disorders concurrently. As a clinician specialized in both eating disorders and substance use disorders, I've found ways to combine the treatment for the two. Here at Within, I've had the opportunity and privilege to work closely with staff to explore creative ways we can approach and treat substance use alongside treatment for a client's eating disorder on our substance use task force. From policy to practice, there are things to consider when meeting the needs for someone struggling with both. So today, we will explore several things, including how stigma and attitudes about substances can contribute to comfort with treating substance use disorders. We'll also explore how substance use disorders and eating disorders are similar and different. We'll look at what substances are commonly used amongst individuals diagnosed with eating disorders. We'll get familiar with assessments used to identify substance use disorders, identify symptoms of intoxication and withdrawal, and seek to integrate treatment for both. So stigma can contribute to the apprehension people might feel for approaching treatment or reporting use. Stigma can also play a role in how a provider has comfort for treating a condition. One of the things that we've learned about in the social history of substances is that many current beliefs and attitudes are actually rooted in racism from many years ago. Let's look at this a little bit more closely. Though commonly used, it is recognized that the term marijuana has racist origins. This exotic sounding name became widely adopted by prohibitionists more than a century ago as a means of emphasizing the substance's foreignness and use among non-white Americans, appealing to the xenophobia at the time. During the Great Depression, as unemployment increased, resentment and fear of Mexican immigrants became connected to marijuana use. In the wake of this, the Federal Bureau of Narcotics was created, led by Henry J. Anslinger, who also started to vilify cannabis, connecting it to Mexican migrants and Black jazz musicians. It wasn't until mainstream white Americans were demonstrating use of cannabis regularly that governments looked to classify it differently from other narcotics and engaged in efforts to decriminalize it. The term cannabis is less historically fraught and stigmatizing. We do know that using terminology familiar and comfortable to clients we work with is the best way to promote connection and rapport. Typically, we find terms like pot or weed being used. So this is something to consider more so when communicating professionally. As this gains traction in the professional communities, the hope would be for it to seep into mainstream use. As we have found with the HAZE efforts, this will take time and energy on the part of those of us informed to make those changes. It is worthwhile to note that use of cannabis in the Mexican community continues to be stigmatized. The social differences between powder cocaine and crack cocaine have demonstrated ways systems of oppression show up in two ways: access and justice system responses to use of and selling of each. Powder cocaine is more expensive and incorrectly thought of to be less dangerous than crack cocaine. Individuals in more oppressed populations have historically have not had access to powder cocaine primarily for this reason. Additionally, sentences related to crack cocaine have been more severe than sentences related to powder cocaine. In 1994, the United States Sentencing Commission began studying the effects of these differing penalties and found that harsher sentences for crack cocaine were imposed primarily on Black citizens. A study revealed that while almost 2/3 of crack users in the US were white or Hispanic, 84.5% of those convicted for crack possession were Black. Opiates were popular in the United States throughout the 19th century, particularly amongst women. Tonics and elixirs containing opium were readily available in drugstores, and doctors commonly prescribed them for upper and middle-class women suffering from female problems. In the 1890s, tabloids owned by William Randolph Hearst published stories of white women being seduced by Chinese men and their opium to invoke fear of the yellow peril. These are only a few examples of how racism has played a part in how beliefs and attitudes about substances have evolved. As providers, we benefit from exploring this in supervision if we're noticing stigma as the primary source of discomfort when working with substance use disorders. Throughout this training, it'll be helpful for us to consider a case example. Here I am presenting to you a 27-year-old heterosexual cisgender female admitted for treatment for her eating disorder, which was diagnosed as anorexia nervosa binge purge type. Symptoms of the eating disorder included restriction, binge eating, laxative use, and purging. There was a history of self-harm. There was also a history of this client being raped, which is important in terms of having experienced a traumatic event. Other co-occurring diagnoses that she came into treatment with were alcohol use disorder, ADHD, MDD, and GAD. Both parents were involved in treatment and they were engaged appropriately. We had them involved throughout. Some stressors that occurred for this client: job loss during treatment, a recent relationship ending, and the loss of a loved one. She was admitted to the PHP level of care. She did also use cannabis at subclinical levels and also demonstrated subclinical symptoms of trauma. Her parents were concerned about her and had her move home. This caused her to be away from where she was living, working, and near social connections. So we'll just keep that in mind as we move throughout this training. Statistics in the eating disorder field note significant overlap between eating disorders and substance use disorders. There is indication of substance abuse and dependence amongst individuals diagnosed with eating disorders at higher rates than the general population by pretty wide margins. Most frequently, we find individuals diagnosed with eating disorders are using alcohol, laxatives, emetics, diuretics, amphetamines, heroin, and cocaine. In more depth, we find that certain eating disorder diagnoses are more commonly linked to substance use, with bulimia nervosa being most prevalent. Stimulants are more frequently found amongst individuals seeking to lose weight. Alcohol and other depressants might be used to assist a person with avoiding more challenging feelings or situations. Some newer information that came out of a study of US veterans explored if there were any gender differences. This study found that bulimic symptoms were found to be more of a predictor in harmful substance use in veteran women, while restrictive symptoms were found to be more of a predictor of harmful substance use in men. There is definitely more need for research in this area, but an interesting introduction to this concept. There is evidence that it takes longer to recover from substance use disorder if the use started before the age of 15. Furthermore, adolescents may be at elevated risk for developing cannabis use disorder. Some studies have shown a link between neurotransmitters in the brain and cannabis, which impacts the brain's ability to interpret pleasure signals from food, which is especially noteworthy for clients also in treatment for eating disorders. Intermittently, I do look to see what updates there have been to the research in the area from the substance use field. SAMHSA, or the Substance Abuse and Mental Health Services Administration, did put out updated guidance for working with co-occurring conditions in 2020. However, information within this guidance continues to be from as recent as 2015. Despite that limitation, there were some interesting findings I'll present here. So the National Treatment Center found that 16% of substance use disorder programs studied offered treatment for co-occurring eating disorders, which highlights the barrier found in the substance use field for screening and treating eating disorders. There also appears to be a lack in relationships with eating disorder treatment providers. While some of this has improved over time, we do know there continues to be room to grow. It is also recommended that there be updated research to see how substance use programs are doing now. Research shown here supports similar findings in the field of eating disorders about the co-occurrence of substance use and eating disorders. The eating disorder not represented here or in other statistics I had found from the eating disorder field is ARFID. It also is noted here that anorexia nervosa restricting type and binge purge type are not indicated separately. These are areas of opportunity in the field warranting further exploration because those symptoms may present pretty differently for an individual. There does also appear to be a parallel relationship between severity of eating disorder symptoms and substance use symptoms. Binge eating disorder being associated with alcohol use has been the most common finding amongst adolescents as well, when cross-referenced with research in the eating disorder field. Attempts to lose weight by purging were associated with stimulant and sleeping pill use. Some have also reported use of alcohol as a way to engage in purging behaviors, but this has been more anecdotal from what I have found. So the next couple of slides are going to show some of the common contributing factors to eating disorders and substance use disorders. As we can see, this list demonstrates that it's recommended to gather a comprehensive biopsychosocial picture of a client, including things like family history, other conditions like mood disorders, safety risks, and social barriers. While this list is describing contributing factors to developing a substance use disorder, I've highlighted factors also found amongst individuals diagnosed with eating disorders. A few of these are highlighted because we do know that there are differences amongst symptoms expressed in different eating disorders. While some clients may struggle with more rigidity and over control, some do struggle with impulsivity and chaotic lifestyle. So taking a look back at our case example to explore some of the contributing factors, we see some similar things. She came into treatment already diagnosed with major depressive disorder and generalized anxiety disorder. There was, in fact, a trauma history, even though symptoms were not meeting criteria for PTSD. She needed to go on a leave of absence from work. She had a recent breakup from her partner, and she lost her grandmother, which all contributed to an experience of turbulent life events. As we got to know her more, we learned that even when she was living on her own and around friends, she was socially isolated. She additionally reported emotional isolation from her parents, even while living with them. We began to learn that alcohol and eating disorder behaviors were functioning to assist her with underlying emotional dysregulation and lack of coping skills. Chaotic patterns were present in her eating disorder symptom presentation, and impulsivity was noted in behaviors related to her socialization and substance use. So next, we're going to take a look at some of the screening tools that are used for assessing for substance use disorder. We will get to identify what each one is and be able to take a look at versions used in the field. A question that comes up frequently when I consult on cases for clients presenting with substance use disorders is what would cause substance use to be identified as a problem or in need of intervention and concern? I'm going to try to address that question throughout the review of each of these assessments. So the SBIRT version we are going to look at is an annual version. This is the Screening, Brief Intervention, and Referral to Treatment Assessment. So taking a look at this, we do see that there are a couple of things to notice. A standardized drink is specified. It is not uncommon for an individual struggling with alcohol abuse to not measure drinks. Sometimes when a client reports drinking one drink, they could be referring to 1 to 4 standard drinks. The reason we may also see assessments separating things by male and female is that there are biological differences in the way that biologically men versus women metabolize substances. An area of opportunity here would be to look more closely at the transgender population when use of hormone therapy is present. This screening is incredibly brief and used only to see if further assessment is needed. Use of recreational drugs once indicates a need for further assessment. Another reason that the number of drinks here is assessed is that the qualification is being looked at for binge drinking. Even one episode of binge drinking can increase a person's risk for ischemic stroke. This would be a flag for problematic drinking patterns. The CAGE is another assessment. It's an acronym. It allows us to assess for a person's use by asking about cutting down use, if people are annoyed by use, if the person has ever felt guilty to use, and if the person has ever had an eye-opener. 2 positive answers would indicate need for further assessment. More concerning positive answers on this assessment would be unsuccessful attempts to cutting back use and the need for an eye-opener. The craft is for use with adolescents. This again is going to be an annual version, and it is the counterpart of the CAGE. Initially, this assessment will ask the individual about general use and then moves to questions more in detail. Like the CAGE, the craft is an acronym, and we're going to take a look at this one as well. So there are 2 versions. I am going to scroll to the interview version. So there is a self-assessment and a clinician administered version. So this gives us a real good walkthrough of how to use this assessment. Collaboratively, this allows the clinician to walk through with the client what the risk for developing or having a diagnosis of a substance use disorder would be based on the scores. So you could see here the CRAFT acronym stands for CAR, relax, alone, forget, family and friends, and trouble. So it's just a kind of a helpful tip of like remembering what aspects this is going to measure. It then offers some opportunity for discussion. So this is where you would be able to discuss with the individual what the risk might be based on the score, and then give some tips on what to do next, and what sorts of responses could be beneficial. So to answer the question about what would be identified as a problem based on this, since we do know that use of substances for adolescents puts them at higher risk for developing a substance use disorder and lengthens the recovery process, use of any substances would be a red flag for a clinician, warranting further psychoeducation and safety planning with the client. When risk to the client's safety is present, involving the client's legal guardians may be necessary. When in doubt, it's beneficial to consult with a substance use disorder specialist or your supervisor. So moving over to the opioid risk tool, and I'm going to just open it up right out the gate here for us to look at it. Many of these assessments are going to indicate at the top how and when it's most appropriate to administer. For this tool specifically, it's typically administered upon an initial visit prior to the beginning for pain management treatment. This assists a prescriber in knowing how high a person's risk might be for developing abusive patterns with the opioid. This is another tool separating things by male and female. It also explores family history, personal history, age, history of sexual abuse, and psychological conditions, which from previous slides, we've learned are among contributing factors to developing a substance use disorder. On this assessment, a score of 4 to 7 would indicate moderate risk and 8 indicates high risk. Because this is only assessing for risk and not current abuse or addiction, the primary response here would be to have high caution with prescribing any opioids for pain. The DAST 10 and 20 seen here will both be annual versions. They will both explore what the nature of a person's use of substances is to identify if it's reaching the threshold for a diagnosis of substance use disorder. So looking at the DAST 10 first, we will see items asking questions about a person's experience and interactions with substance use, impact to the person's functioning, and symptoms associated with more problematic use. It is DAST 10 because it is 10 questions long. And in terms of scoring, we see that the DAST 10, anything over a 3, warrants further investigation, with 6 and above warranting intensive assessment. We're going to get into diagnosis in a little bit, and so we'll be able to see what some of the criteria of that is. Moving over to the DAST 20, I'm going to just make this a little bit bigger for people. We can see that there is overlap with the DAST 10, but it goes a little bit deeper. More specifically, the DAST 20 asks questions about social and work impact of substance use, and also asks if a person has sought treatment for substance use in the past. When I scroll down to scoring, it also takes things one step further and gives advice on the type of intervention a person might need. We see here that scores between 6 and 10 indicate possible diagnosis and warrant treatment. Scores of 11 and up indicate need for intensive treatment. So for concerning results on either of these, a score of 3 and above on the DAST 10 and a 6 and above on the DAST 20 would indicate need for specialized consideration that may impact treatment. The audit, or the Alcohol Use Disorders Identification Test, has standardized clinician-administered and self-report versions. A score of 8 or higher on this assessment is considered to indicate hazardous or harmful alcohol use. This has been validated across genders and with a wide range of racial and ethnic groups. It's well suited for primary care settings as well. I'm going to go to the self-report version just for the ability to see the questions on here. We can see that it asks questions important for diagnostic purposes, including how many drinks a person is consuming, if a person's able to stop using, needing to have a drink first thing in the morning, whether or not there's blackout or brownouts, risky or reckless behaviors, and being told that use was concerning by others. Standardized drinks are also outlined on the last page of this assessment as a guide. A note about blackouts and brownouts. A blackout occurs when enough alcohol is consumed to prevent memory formation. Clients reporting blackouts will have entire blanks for portions of the time they were intoxicated. Brownouts, on the other hand, are lesser of a version of this, where a person has a foggy memory formation of what may have occurred. The primary difference here is whether or not memory was formed. This is just an important note to consider when working with someone who has experienced trauma while intoxicated. So a cause for concern on this assessment would be a score of 8 or higher. The DUDIT is the counterpart of the audit and is for drug use other than alcohol. So let's look at our case example again. When we look back, 2 assessments stand out as important to get a better understanding of this client's substance use. For myself, felt that it would be important to administer the CAGE and the audit. This client scored a 2 on the CAGE. She felt annoyed when others talked about use, and she also felt guilt about use. And then on the audit, she was scoring at a 14, well above the score of 8, indicating concerning and hazardous use. So moving forward to misuse, abuse, and addiction, it is important when working with individuals that we can distinguish between these things. Not all use requires intervention. Drug misuse happens when medications are taken for a purpose that's not consistent with how it was prescribed. Examples include taking the incorrect dose, taking the medication at the wrong time, forgetting a dose, stopping the use of a medication too soon, taking the medication for reasons other than why they were prescribed, and taking something that was not prescribed to you. Abuse of a substance is typically where we will find emerging substance use disorder diagnoses. This is different from misuse because of the intent a person has. With abuse, a person is typically looking for the substance to elicit certain effects, such as a high. A substance can be anything that creates a high or has a psychoactive effect on the brain. Addiction is considered a more severe version of substance use disorder, where we might find a person developing dependence, withdrawal, and tolerance for a substance. The primary difference between this and abuse is found in the person's ability to control use. Usually, when someone is struggling with more severe substance use continues despite creating problems for the person's life and functioning. Dependence, more fully described here, does not occur with every substance. It also does not occur for every individual who uses these substances. One of the only ways this is discovered is when a person tries to reduce or stop use of a substance. It is, for this reason, very important to develop a strong therapeutic alliance with clients presenting to treatment with substance use disorders so that we can have open conversations about this and any other risks. Alignment with the client is a strong factor in the client disclosing information that could make them cause them to feel vulnerable. So as previously discussed, abuse and addiction are forms of substance use disorder. Diagnosis of substance use disorders are outlined in the DSM. This is a general version extracted from the DSM that is found amongst all substances. At least 2 are needed from the following list, which there's 3 slides here for this. So that's actually important to consider, that only 2 criteria are needed to meet diagnostic criteria for diagnosis. We're not going to spend too much time on these slides since we can find this in the DSM, but it's helpful for us to see a list of these things to have awareness of for further discussion. Not seen on these slides also are specifiers. There are specifiers for substance use disorders. They are going to determine the severity of use. So speaking about alcohol use disorder, 2 to 3 symptoms would be mild, 4 to 5 would be considered moderate, and 6 and more would be considered severe use. Specifiers can also indicate whether the substance use is in remission, early or sustained, and whether this remission is due to being in a controlled environment. Withdrawal, although it is listed, is not always going to be applicable to every substance, but is important to note nonetheless. So if we think back to our case example, and as we're getting to know her, the questions that kind of come to mind are, what were we looking at? After much rapport building and exploration of symptoms and use patterns for this client, we were able to diagnose and reinforce the diagnosis of alcohol use disorder moderate with 4 to 5 symptoms present. So the symptoms that we found, desire to control use. She did have a denial present for needing to stop use, though. A great deal was spent trying to recover from the effects of alcohol. She experienced cravings for alcohol when she was not drinking. There were important social and recreational activities being given up or reduced. And she continued to use, even though she was aware that in combination with her eating disorder, her physical risks were higher. So being malnourished does impact the way alcohol or other substances is absorbed into the system, which resulted in erratic patterns of intoxication. One of the primary reasons the specifier was not severe was that there were some things missing that just were based on the environmental factors. She was living at home, she was not engaging in any work or school, and safety was being supervised by her parents. So, we sort of had an absence of that information to diagnose with a severe specifier. So now that we know general aspects of diagnosis, we're going to take a closer look at intoxication and withdrawal from commonly used substances. With any potential use of substances, it is important to verify that a substance has been used if you are seeing symptoms of intoxication. Symptoms without use of a substance could be signals of concerning medical issues arising, including neurological issues. So starting with alcohol, alcohol is a central nervous system depressant. Intoxication will typically involve slowing of systems or lacking ability to do things mechanically. One or more of these symptoms would be present with alcohol intoxication. Slurred speech, incoordination, and impairment to attention are very commonly observed when an individual is intoxicated. Withdrawal from substances usually presents with symptoms that are opposite from the effects of the substance when a person is intoxicated. This may not always be the case, but it's sort of a useful tip to remember intoxication versus withdrawal. It's important to know what the substance is that the person is using to also guide that awareness. Symptoms of alcohol withdrawal can be fatal. Close medical monitoring of withdrawal symptoms is imperative. It's important to always work closely with a person's medical team to monitor symptoms. There unfortunately is no pattern or progression of withdrawal symptoms, so one person can experience a seizure first, and another person might never have a seizure. For this reason, awareness of withdrawal risk should be treated very seriously. Benzodiazepines have predominantly replaced barbiturates for treating alcohol withdrawal symptoms. Use of a benzodiazepine should be short-term and only for the purpose of reducing withdrawal symptoms. Long-term use of benzodiazepines have their own set of risk factors, including addiction and withdrawal. Withdrawal from the extended use of benzodiazepines can also kill. This can include Xanax, Ativan, or Valium. Long-term use of benzodiazepines requires medical supervision to be discontinued successfully with minimal side effects and risk to the patient. Stimulants include cocaine and methamphetamines. Here we see a person might experience increased central nervous system functioning as evidenced by pupil dilation, weight loss, psychomotor agitation, confusion, and changes to vitals. Stimulant use is especially concerning for individuals also recovering from eating disorders due to the impact stimulants have on appetite. In terms of withdrawal, we will first look for dysphoric mood, along with 2 of the following. We also see signs of the body needing to catch up on things that might have been suppressed while stimulants were actively in the system, such as increased appetite and fatigue. For opioids, we'll always see pupillary constriction for intoxication. This is a primary difference between this class of substances and others we have discussed. The opioid class of substances includes heroin, fentanyl, morphine, opium, oxycodone, methadone, tramadol, and codeine. Currently, there are 24 substances that fall under this class. Opioid withdrawal can include complications which can be fatal. However, withdrawal from methadone has fatal risks on its own. We'll talk about medication-assisted treatment later, but that's important to recognize because methadone is a medication-assisted treatment for opioids. Yawning, lacrimation, and rhinorrhea have anecdotally been reported to be a very common indication of opioid withdrawal. So lacrimation would be tearing eyes, and rhinorrhea would be a running nose. Clients often report using cannabis to increase appetite and interest for food, manage anxiety, and manage symptoms related to bipolar disorder. Unfortunately, there is evidence that cannabis can be linked to increased anxiety and incidences of a manic episode for individuals. Unfortunately, too, this can also increase likelihood for abuse of cannabis. As a mild hallucinogenic, cannabis is also considered a central nervous system depressant, which can have problematic effects for someone with a mood disorder. Intoxication can include hallucinations. It is beneficial to note that clients with mood disorders may also likely be prescribed medication to assist with symptoms, and use of cannabis can interfere with those effects. There have been efforts in the medical field to isolate components of cannabis that are more medically useful from the psychoactive components. Cannabis not regulated can be laced with substances which can prevent risk for things like overdose and even death. This can also change intoxication patterns. Something that is most frequently laced with cannabis, unfortunately, is fentanyl. It is also worth noting that it is impossible to know what the concentration of THC, or the psychoactive component of cannabis, is prior to use. So I feel like something that's not typically talked about is withdrawal from cannabis. It is something worth looking at, especially for the use that we typically see people engaging in it for, which is typically to help with things like sleep and anxiety. Withdrawal occurs for people engaging in heavy and prolonged use, which would be daily over the course of a few months. It is important to provide education to individuals because it can have a counter effect on things that they were looking to get out of use in the first place. So increased anxiety, trouble sleeping, and decreased appetite are seen here. Because withdrawal can occur from this substance after heavy and prolonged use of cannabis is not a sustainable option for managing symptoms of other mental health conditions. Someone predisposed to or struggling with depression and anxiety is not a good candidate for cannabis use. So from a learning standpoint, I had the opportunity to apply the previous information we just learned to my work with this client. At one of my sessions, she arrived clearly intoxicated. I proceeded to ask questions about her mental status and reflected what I was observing. Initially, despite our strong rapport, she denied any use. Denial was a primary barrier for her, and it was something that we continued to work on throughout her treatment. I reflected to her my concerns and that what I was observing was either due to alcohol intoxication or an emerging neurological condition that she would need to get immediate attention for. Upon further denial, I invited her parents into the session, which this client was amenable to. She and her parents had previously engaged in effective family therapy. We proceeded to discuss concerns with her, and her parents reinforced that what they were seeing was not what they were accustomed to when she was sober. Previous work with them had paid off. Finally, she was able to acknowledge that she was under the influence, which promoted further discussion about next steps. We made a plan for safety, and for the remainder of the day, we discontinued the session so that she could come back to a sober mind. At a later session, we engaged in discussion about withdrawal symptoms and planning for what to do if withdrawal symptoms started to present. She became more open to talking about use and also any symptoms she was experiencing, and luckily, we did not need any medical intervention. So now that we have more of an understanding of substance use disorder diagnosis and symptoms, we're going to talk more about treatment. The hope is to find areas that treatment can overlap so that a person's eating disorder and substance use disorder can be treated simultaneously. So these are treatment modalities specific to the field of substance use disorders. While there are some parallels in philosophy for treatment of eating disorders, such as harm reduction and levels of care, it is important to note that other treatments are found more regularly in the substance use field. We're going to look at those more closely. First up is prevention and intervention. So primary prevention aims to prevent injury before it even occurs. This is done by preventing exposures that can alter unhealthy or unsafe behaviors and increasing resistance to disease or injury should exposure occur. Secondary prevention aims to reduce the impact of a disease or injury that has already occurred. So detection and early treatment is the way that we use secondary prevention methods to slow progress of a condition. Tertiary prevention aims to soften the impact of an ongoing condition that has lasting effects. This is done by helping people manage long-term, often complex health problems and injuries in order to improve quality of life. Intervention typically refers to a structured approach by the support system with a trained professional to encourage the person to seek treatment for substance use. The individual may not be motivated for treatment, and intervention additionally serves as a space to set healthy boundaries for both the person and the support system in the event that treatment is not sought. Detox can be done at both the inpatient levels of care and outpatient levels of care. Ambulatory detox is what outpatient level of care detox is called. It is a little bit newer to the field. It should be carefully considered. There are pros and cons to both options, so it's important to engage a person in an open conversation about what approach would be most supportive to them and their needs. The 3 steps that we're going to look at are evaluation, stabilization, and fostering the patient's entry into treatment. Evaluation entails testing for the presence of substances in the person's system, screening for co-occurring mental and physical conditions. Evaluation also includes a comprehensive assessment of the patient's medical and psychological conditions and social situation to help understand the appropriate level of treatment following detox. This sets the stage for treatment next steps. It helps to identify and understand a person's unique needs and figure out what type of treatment and what level of care would be most appropriate, and where the treatment plan really begins to get developed. Stabilization includes medical and psychosocial processes of assisting the patient through acute intoxication and withdrawal. The hope is to get to attainment of medically stable, fully supportive, substance-free state. This is often done with the assistance of medications, though in some approaches to detox, no medication is used. Stabilization includes familiarizing patients with what to expect next in the treatment setting and their role in treatment and recovery. During this time, it's usually recommended to involve the patient's full support system, which could be anyone, family, employers, community supporters, friends, and we do so when appropriate and with informed consent. One of the most important parts of getting a person into treatment is fostering their understanding of the importance with continuing treatment. Some will complete detox, but then not complete the continuum of care to address the substance use disorder. As a person has more time away from substances, their ability to recognize the need to continue with treatment may wane. Sometimes treatment providers will have a person sign a contract agreeing to continue with treatment and demonstrate awareness of the risks to not doing so. Stability and clear-mindedness are required for a person to understand this fully. Because complete departure from substance use is not realistic for every person, it is valuable to look at harm reduction options. We do want to first consider safety, though. This could mean that harm reduction is an option, or it might not be an option. This can depend on the type of substance being used, the method of use, the severity of use, and the risk-taking that might be involved in use. If safety can be optimized, it is important to meet a person where they're at in order to get them to keep an open mind down the road for further adjustments to their relationship with substances. At substance use programs, clinicians able to administer toxicology are sometimes present on site. When working with clients in a remote eating disorder treatment setting like Within, it's been valuable to have close relationships with primary care providers to advocate for toxicology. Sometimes this is the only way to promote accountability initially for clients. Toxicology can be set to different specificity, which is what type of substances are being tested for, and sensitivity, which is how much of the substance needs to be present in order to be detected. Typically, we'll see urine as the primary toxicology method, although some substances might be found in urine for shorter periods of time than blood or hair. Substances remain in hair forever. Primary barrier to using hair as the toxicology method, though, is the amount of hair needed and not being able to tell when the use occurred because it's there forever. Best results come from hair that is pencil thick in diameter with the root, so we can see some obvious challenges to use of that method. For use in treatment settings, urine toxicology is the primary go-to. Another factor determining the length of time we would be able to detect a substance is that each substance remains in the system for different periods of time. It's important to know what substances you're wanting to test for because that will assist you with method and timing. So medication-assisted treatment, this is helpful for clients who may struggle with withdrawal and initial significant levels of craving for a substance. Initial discontinuation of a substance is incredibly challenging and can even be dangerous. Medication-assisted treatment can assist with taking that edge off of the initial phase of abstaining while the client develops other strategies and skills to adjust their functioning. Some medication-assisted treatment is utilized as part of detox, and some is also utilized as temporary, moderated replacement for the substance so that a person can focus on treatment with less impact to their cognitive functioning. Always important to know what providers will prescribe what, as some will not prescribe all medication-assisted treatments. So, the practical ways of managing substance use in the eating disorder treatment setting. Several ways have surfaced. At the top of the list and of top priority is the relationship we develop with the person receiving treatment. Having openness and honesty is one of the first steps to recovery from substance use. It is important, just as with any other area of treatment, that if we're not well trained in an area, that we consult with a specialist. Titles of substance use specialists vary by state and training. Specialists in the substance use field can be CASACs, CACs, LCADCs, LCDCs, and LCDPs. Sometimes adding support groups to a person's treatment plan can also be a beneficial addition. This can include AA or SMART recovery. It is valuable to explore with a person what kind of support would resonate with them the most in order to refer them to an appropriate type of support. We've also found that it can be helpful for clients coming into treatment with co-occurring substance use disorder to have an additional team member assigned to them with the sole purpose to check in on how the person is doing with either remaining abstinent or pursuing sobriety. Just like in the eating disorder field, it's important to approach substance use disorders with a multidisciplinary treatment team. Here at Within, we named this the Pathfinder program. An additional staff member with experience in the substance use field would be assigned to a client to meet with them each week. This additional team member was then overseen by me, a CASAC. Further development of this program is an exciting venture for us moving forward. For motivational interviewing, it is important to be prepared that not all people will be interested in pursuing sobriety. Conveying the importance of abstinence in order to stabilize both the eating disorder and substance use disorder is important, and then exploring what a person wants their relationship to look like is typically a more accessible conversation when someone is in early recovery from substance use. Some notes about treatment recommendations potentially conflicting. Some substance use recovery programs advise diets and intense exercise to address vulnerability factors contributing to substance use. This is important because if we are working with somebody also with an eating disorder, this recommendation is not appropriate. Similarly, sometimes people who are in eating disorder treatment may be prescribed medications or treated with newer medications that could have addictive properties that might be psychoactive or create a high. We have seen an increase in the use of ketamine treatment in the mental health field. This is one example. If the client has a history of or a risk of substance use disorder, certain medications and treatments would also not be appropriate. So always just really important to know all of the different angles that a person needs to be treated with. People also often use food and substances to help them cope. A person in recovery from an eating disorder may use substances to cope with the stresses of recovery. Similarly, a person in recovery from substance use may use disordered eating to cope with or compensate for the lack of chemical reinforcement. Neither process of recovery is linear. For this reason, it's important to be on the lookout for possible symptom swapping as treatment and recovery moves forward. While symptoms of one condition could be subsiding, it's not uncommon to see symptoms of the co-occurring condition intensify. A recommendation for this is to keep lines of communication open, promote engagement, and engage in safety planning. In my experience, when a client sees that I'm accepting the peaks and valleys of recovery, the level of engagement increases. The great news is that modalities we are typically trained in for the eating disorder field are also pretty applicable for the work with substance use disorders. One thing I like to always remember is that someone coming into treatment is not always ready to change, so leaning on motivational interviewing and motivational enhancement therapy can be really, really beneficial to weave throughout treatment, especially in the beginning. One of the most effective modalities for treatment for substance use disorders has been group therapy. It's also the most widely used in the substance use field. Anytime peers can sit down with one another and challenge each other has the potential for resulting in unique breakthroughs. One of the common threads amongst all of the modalities is cultivating healthy boundaries and loving limits. As we know in the eating disorder field, it's vital to involve families and supporters. The same is true for substance use. Isolation for both conditions is a perpetuating factor. Like links in a chain, skills that are useful for both eating disorders and substance use disorders are listed here. There is no order to follow necessarily, so just meeting a client where they're at and what they need the most is the best way for meaningful engagement. For accountability, I like to work with clients to develop comfort and willingness to be open with all providers or with what they're struggling with in order to mitigate inappropriate treatment recommendations. If a provider is not aware of an eating disorder, they may recommend problematic things like diet or exercise. If a provider is not aware of a substance use disorder, they may prescribe medications that could result in relapse. So when it comes to our case example, we learned quickly that she was primarily in pre-contemplation, often residing in a place of denial. While we were able to move towards contemplation throughout her treatment, there were many barriers related to treatment for this particular client. Nonetheless, we included things like family therapy, psychoeducation, support groups, and podcasts to assist with curiosity, toxicology, and management of the environment. So ultimately, what happened was that we were able to stabilize the eating disorder symptoms, making her appropriate for a substance use program. She remained in pre-contemplation and contemplation. She was referred to a substance use program, and from what we were aware of, we received correspondence that she successfully admitted to a substance use program once we were done with her here. So based on this outcome, we as a company found two primary places that we had an opportunity to grow. Every client teaches us something new, and we're always looking for places to improve our services. We needed more space therapeutically for her to tackle both. This allowed us to consider the addition of a team member and the way to allow clients to have access to treatment even when struggling with substance use disorder allowed us to take a look at our policies. Anecdotally speaking, these are the components that have been noticed in situations where treatment of substance use disorders has worked in our setting, which is primarily focused on eating disorder treatment. The goal is to work with clients to get here and, if able, continue to do the work here. When clients are not ready to get here, we explore referring to programs to more thoroughly meet substance use disorder needs. So the substance use field does have recommendations for providers to assess for eating disorders. This is just a list of different things that practitioners can do, questions that they can ask to be able to get a sense of if substance use disorder might be happening, if eating disorders might be happening. One of the challenges is that there can be some conflicting treatment recommendations. Professionals in the eating disorder field believe that it would be beneficial to treat the eating disorder first, whereas in the substance use field, they typically feel that it would be best to tackle the substance use first. Both do talk about it being best to treat both concurrently when able. This is not always something that is possible, though. So this can be confusing too. Something that's very important to ask ourselves is what is in most need of triaging? Is a client at risk of of withdrawal? Is a person at risk of refeeding syndrome? What would need to be stabilized first in order to promote medical safety? So this is a list of similarities and differences between the recovery processes. One of the things that I've heard from clients often is that it is frustrating that recovery from substance use involves avoiding a substance, whereas recovery from an eating disorder requires a person to redevelop a healthy relationship with food, movement, and their body. This is not untrue, but there are some similarities that are beneficial to lean on as well. So just some considerations for further exploration. The biggest standout for me is need for more access to integrated treatment models in both substance use and eating disorder fields. And then finally, we know that there are similarities to contributing factors for eating disorders and substance use disorders. We know that some of the treatment modalities overlap, and recovery means looking at what we need to do in order to change our thoughts and behaviors. We also know it's important to assess for safety and tackle what is presenting with more of a safety concern first. It's important to ask ourselves if detox or withdrawal is a risk, or if a person might be at risk of refeeding, to know how to triage initially. When possible, the best outcomes occur when we treat co-occurring conditions concurrently. We've learned that this is true for PTSD, OCD, and mood disorders. The same is true for substance use disorders. It's also important to prepare clients for the difference in recovery process from both. In the 1 minute.
Thank you, Cheryl. I can definitely say, wow, that was an incredible presentation. That was so insightful, so informed. So thank you so much for sharing all of that. We're so excited to have you here. I want to provide both Jamie's and myself's email in the chat. If some questions do come up, feel free to email us those and we can give them to Cheryl. I want you to make sure you're seeing all the love in the chat as well. I also want to let you all know that we have some incredible presentations on the horizon here at Within. We have our next provider series that will be coming up. That'll be September 20th at 1 p.m. Eastern. That will be the male body mirrors. We also have our Within Health Summit that will be coming up as well, and that will be October 11th or 8th through the 11th. Both of those are found on our social media site, so please make sure to register for those wonderful events that we have coming up. There are going to be some really great presentations coming from the Within staff. Thank you all again for joining us today. Thank you so much, Cheryl. That was amazing, and we are so excited to have you all join us today. Thank you all.
Thank you.